what is the prostate gland? So I hope you can see my little arrow. So here's a cross section of the male anatomy, and here is the bladder, the urinary bladder. And right below the bladder is the prostate gland. And that is usually described as something the size of a walnut. So it's really not very big. It's quite a small gland. And the urine tube, otherwise known as the urethra, passes from the bladder through the prostate gland and then out through the penis. And the prostate is composed of several lobes and has a relatively complex anatomy. So what's it good for? Because it causes people a lot of problems, so it better be good for something. So what the prostate gland serves to do is it makes the fluid that then accompanies the sperm that are made in the testes, that are then shipped up to the seminal vesicles, which are at the back of the bladder. And when the man has an ejaculation, the sperm comes through the seminal vesicles mixed with fluid, and then the prostate increases the fluid and lubricates and provides nutrition for the sperm as it then is passed out through the penis. So it's quite a useful organ, but it can cause difficulties. So when there's an issue, so prostates can just become inflamed, they can get infected, just like any other organ. You can have an infection of the prostate, an infection of the bladder, and so on. But unfortunately, it can also develop cancer. So what is prostate cancer?
That's fine, Dawn.
So as you may know, basically cancer starts in a single cell. And what happens in normal cells, the cells are programmed to grow to a certain size, divide, have children, and then die. And that is what that's programmed into normal cells. But cancerous cells become, due to what we might call a mutation in their program, they tend to grow out of control. And this is basically what happens with any cancer. So the cell no longer listens to excuse me, the programming, and they just continue to grow abnormally and then really can cause problems for people. And this also happens in the prostate gland. The cancers in the prostate gland tend to start in what we call the peripheral zone here on the edge. And this is one of the reasons why one of the tests which we'll talk about, which is the doctor feeling the prostate, because you can actually feel whether there's an abnormality. There are many other things that can happen in the prostate, and one of them is called benign prostatic hyperplasia, which is not cancer, but can lead to an enlarged prostate and difficult problems with urination and so on. So we're not going to talk about that. We're going to talk about cancer specifically today. So who is at risk for prostate cancer? Well, starting off, being a man, unfortunately, puts you at risk because you should have a prostate. And in fact, prostate cancer is the most common cancer in Jamaica, and it's actually the leading cause of cancer-related death, even more common than breast cancer. So, you know, it's definitely something that people should be paying attention to. The Caribbean, we have one of the highest death rates from prostate cancer in the world. And in Jamaica, we have one of the highest incidence rates in the world, meaning that, you know, Jamaica, if you were to do a table, we would come very close to the top of prostate cancer being the highest rate in the whole world. So that's a little worrying, I would have said. And then we have a cancer registry that looks at Could we just ask folks to mute their mic? Thank you. So in the 3 years between 2008 and 2011, just in Kingston and St. Andrew, nearly 900 cases of prostate cancer were seen. So if you do the math and divide 900 by 3, that's about 300 new cases a year. And this is just in Kingston and St. Andrew. This is not in the rest of Jamaica. So you can imagine that that's really quite a lot of folks. So are there folks who are at greater risk, and what would those risk factors be? So there's 3 established risk factors, and age, unfortunately, is one of them. So as men age, their risk of prostate cancer increases. And just for the women out there, the same is for breast cancer as well. So it's not just the men who have to be, watch what happens when they age. So the peak of diagnosing prostate cancer comes between 65 and 74. It's very rare before 40. I don't think I've seen anybody below 40 with prostate cancer, but it's terribly common in that age range there. Unfortunately, it is also more common in men of African descent, and that's seen in the US. African Americans are a much greater risk than their white Caucasian counterparts. And then the other thing that increases your risk is whether there's a family history. So your father, your uncle, your brother, whether it's an older relative on either side. So it's not just on your father's side, it may also be on your mother's side. Her father may have had prostate cancer, her brother may have it, and so on. So any close relative who has prostate cancer means that your own risk is going to be increased. And therefore, that means a greater awareness and a greater paying more attention to being tested and so on. And we'll look at what those tests might be. So there are also some other risk factors that are sort of what we would call finer print and are still being researched. So diet, men with higher testosterone levels, men who are overweight seem to maybe increase the risk. And then, of course, there's the lifestyle factors, which really are risks for any kind of cancer. But in particular, in prostate cancer, a high intake of red meat and dairy products, so you mean milk and cheese, can certainly increase the risk, and high risk intake of saturated fats, which basically means meat products. And then overeating, which I guess would then lead to a high body mass index and overweight. And that's a risk for a whole heap of things. So, we can't just single out prostate cancer. As you know, that's a risk for diabetes, hypertension, and many other sorts of, and heart disease, of course, and other types of cancer. So the lifestyle is something that we should be looking at, not just because you're worried about getting prostate cancer, but because you need to keep healthy and not develop other things that might complicate your health. So are we able to do things to prevent getting prostate cancer? There's a lot of words here, so we'll just go through. And I think it's important to recognize that you can't actually primarily prevent it, but you can reduce your risk by, reducing some of the things that we mentioned. So reducing your fat intake, particularly fats from meat and dairy products. And this is advice, I'm going to say, across the board. So you always want to be increasing your intake of fruits and vegetables. We talk nowadays about a rainbow diet, and there's a picture of the gentleman with a lovely looking rainbow salad bowl there. So you should always have many different colors of foods on your plate. Cruciferous vegetables, broccoli, cauliflower, tomatoes are very good. Avoiding red meat, processed meats, all of those things that you see there, like unfortunately corned beef is processed, all those sliced meats and so on, and charred meat. So if you're into barbecuing and having burned foods, and unfortunately we quite like that in Jamaica with the jerk pork and the jerk chicken. So I'm not telling you don't eat it, but just be mindful that those things eaten in quantities can increase your risk of pretty much anything, but including prostate cancer. A good lifestyle choice is regular exercise and maintaining a healthy weight, and that will definitely reduce your risk of many things, including prostate cancer. Interestingly, there's quite a lot of research now on vitamin D. Now, vitamin D is an essential, it's actually a hormone, and you get it from sunlight and from foods. And I just want to spend a few minutes on this because, of course, pigmented peoples do not sit in the sun, right? We sit in the shade. And if you are to sit in the sun, because dark-skinned people, you actually need more sunshine to get the vitamin D that you need. And it's, and it's, if you imagine, well, we spend a bit more time outside maybe than our African American counterparts who may be indoors more, a lot more office jobs. And there's a definite link we're realizing now between low vitamin D and increased risk of cancer. And if you do have cancer and your vitamin D is low, and this actually goes for breast cancer and colon cancer as well, that you would do very, very well to take vitamin D as a supplement and just as part of a healthy lifestyle. So the vitamin D we're talking about is vitamin D3. And just to say that we generally recommend the dose is 2,500 international units a day. And you should just really incorporate that into your regular supplements if you take them at all. And then there's these medicines that, you do not go out and think this is going to save you, but we have noticed that folks who have what we call the BPH, the benign prostatic hyperplasia, the enlarged prostate that may cause difficulties with urination, doctors have noticed that gentlemen who are put on those medicines to help reduce the size of the prostate may reduce the risk of prostate cancer, but it's not something that you take just as a regular thing. It's there to treat something and may reduce the risk. So let's look at some of the things that you might feel if you were having a diagnosis of prostate. I think the most important thing to say is that early prostate cancer, you will not know that you have it. It can be there in your prostate, you will not have a single sign or symptom. And that is important to understand because you say, "Sure, man, my prostate fine, I don't feel anything." Your prostate can have quite a lot of cancer in there and you still don't feel anything. The time that you're going to notice that you have problems is when it has become advanced, and that may be when it's maybe too difficult to treat and may have already spread around your body. So gentlemen, please do not wait until you have a problem before you go and get checked out. The whole point of, and we're going to talk a little bit about screening, is to do it when you don't even recognize that there's an issue in your prostate. That means it's probably early and we can catch it early and treat it and cure it. But when it does become advanced, here's this poor gentleman having difficulty starting his urination. What we call hesitancy. He may stand up there for a good little while and it doesn't come. The stream, which obviously also changes with age, but you might find that if your prostate is not well, that your stream is not so good and you can't pee like that 3 feet that you did when you were 18. You may be waking up at night very frequently to pass urine. You may see blood in the urine, or when you have an ejaculation, there may be blood in the semen. If you're having discomfort in your back, or your, as we might say, belly bottom, your pelvic area, then that generally means you have quite advanced disease. So you would not want to know that you're waiting till that point. You may find that, erectile dysfunction tends to come with aging as well, and other illnesses like diabetes and so on. But prostate cancer may also cause that. So I just also want to say that all of this list of things can be caused by many other things other than prostate cancer. So I don't want you to freak out and think, oh my God, that's what I have. But what I'm doing here is trying to raise your awareness that some of these issues may indicate that you have prostate cancer. But the best thing is not knowing that you have it, but that it was picked up early by a blood test. So let's talk a little bit about that. So how do we diagnose prostate cancer? So the most simple way is by doing a blood test. And the blood test is looking for something called the PSA. Now, the PSA is a protein that is made by your prostate gland as a normal thing. But if it starts to rise out of the normal range, we start to get a little suspicious. It can be that you have an infection. It can be just irritation. If you ride a bicycle a lot, you can cause irritation in your prostate. Not to say you shouldn't ride a bicycle, but sometimes gentlemen who ride a bicycle a lot will find that they have a higher PSA, but when it's really checked out, there's nothing really wrong with the prostate. So a PSA test is the most simple and basic way of looking at the prostate. And if it is high, I know a lot of folks are very, turned off by the idea that the doctor might put the finger in the back passage. And you can see from the picture, that's right, the prostate is right there. It's easy to feel. And remember what I was telling you, the prostate cancer starts in the edge of the gland, so that in fact, it's very easy to feel with the finger. The doctor is not generally going to check your prostate with a finger unless your PSA is abnormal. So if you have a normal blood test, great, you're gone on your way. You did it for this year and you come back and you do it again the following year. However, if it is abnormal, the doctor is likely to want to check it like that. And that's a simple, free, no money, apart from maybe the doctor's fee, or you go to your health center and it's done for free. But it's a really simple test and you can get a lot of information. It takes about 30 seconds or less. So I really think that folks should not be worried or afraid. And you can see from the diagram here how easy it is for the doctor to feel the prostate, because it is just right there, in the bottom part of the back passage. So here we are, somebody having their blood taken. And there's a lot of controversy internationally about what age you should start to be screened and how often. But because we are more at risk in our population, the recommendation by the Jamaican Neurological Society is that you should really start when you're 40. And absolutely, if you have a relative with prostate cancer, you must start when you're 40. And what we're saying is do it once a year. I mean, if it is abnormal, they might say, come back in a couple of months and we'll check it again. But generally, a once a year blood test is one of the things that could save your life, actually. So I encourage you to do it. And to start looking after your health by getting a regular test. So just like we talk about women doing their self-exam for breast cancer and getting their mammogram when they get to 40 or a little older, getting a PSA test is what we recommend for men. And generally, we would recommend that up to the age of 70. So moving on, how do we diagnose it? So now if we're worried, your PSA is high, we treated an infection and the PSA is still high, so it's not really an infection. So what we need to do now is to take a biopsy. And a biopsy is a word that means we're going to take a piece of the prostate tissue, send it to the lab, and then the technician will have a look down the microscope to see if it looks like the prostate has cancer cells. So the biopsy is generally done by a urologist, and the urologist is a specialist in all things prostate and bladder. And so they are trained to do biopsies, and it is done through the rectum. So just like you saw that finger in the last picture, the doctor will insert a probe into the rectum so they can see the prostate, and then there's a needle attached to the probe that is then passed into the prostate. So generally you have some form of anesthetic so that you don't feel it. You may be awake but a little bit sleepy, and most men are, don't have a problem, and it's done quite quickly, and you go home at the end of the day. So it's not something that requires hospital admission. So once the doctor has, normally they will take at least 2 needle cores, we call it. But some of the biopsies nowadays take up to 15 or 16 cores, because what they don't want to put the needle in the prostate and miss anything. So they may take quite a few cores, and then those are looked at under the microscope in the pathology lab. To say, is there cancer, is there not cancer? And then we also look, okay, if there is cancer, what grade is it? The degree of aggressiveness of the cells, is it what we call mild or moderate or severe? And that also gives us an indication of how soon we need to treat and what kind of treatment we need to offer the person. So when we discover that the person has cancer, the next thing that we need to do after the biopsy is to do what we call staging. So staging is made up of many different parts. So you would have had your PSA, the prostate would have been examined, you would have had your biopsy. But then we also need to check, has it gone anywhere else in your body? So we do special x-rays like a CT scan. We would look at your chest, we would look at your abdomen, we would look at your pelvis. We do a bone scan, which is another type of x-ray, because one of the things, the first place prostate cancer generally spreads is into the bone. So we always do a bone scan to make sure that that has not happened. And nowadays we actually do an MRI, which is using special magnets. That is actually a better way of looking at the prostate than the older CT scan. And the good news is that most of these investigations are available in the public sector. So you don't feel you have to say, boy, I can't manage, I don't have the money. The government is covering most of these tests. So if you are worried, you can go through your health center into the public sector, and you can get your CT and your MRI and your biopsy all done in the public sector. So that is what we call clinical staging, when we use those types of x-rays and so on to see if the cancer is just confined to the prostate or whether it has spread. And then the pathologic staging now would be if the person actually had surgery to take the prostate out. That would give us a lot more information. So we'll talk a little bit more about that further down. So I hope if you're having any questions, please jot them down and we go to those at the end. So this is staging prostate cancer. So stage 1 is when it is just in one half of the gland. The gland is divided into two halves. And if it's just in one half of the gland, one spot or a couple spots, but in one half of the gland, that would be stage 1. And if you're going to have prostate cancer, of course, that is where we want to find it, at stage 1. Stage 2 is when it's in both halves. Stage 3 is when it may be that the prostate is enclosed in a capsule. And stage 3 is when it may be starting to eat through the capsule, which is like a tight skin, or it may even be going upwards into what we call the seminal vesicles. And stage 4 is when it may be going up into the bladder or into the rectum. So obviously that is what we would count as advanced prostate cancer. And we hope that, we find folks long before we get to that stage. So how do we treat it? So let's say you have a diagnosis of stage 2 prostate cancer. It has not spread. All the tests show that it's confined to the prostate. So what are we going to do for you? So I think it's important to recognize that there's no one size fits all. It depends on a lot of things. And really, it should be a shared decision-making process. Obviously, the doctor is going to give you, tell you what the options are based on the stage, based on your age, based on whether you have lots of other issues. So the treatment is probably going to be different if it's a stage 1 and you don't have diabetes, hypertension, heart disease. That treatment is going to be different than if you're a stage 3 and you're diabetic and you weigh 300 pounds and you have pressure and so on. So it's a very individual thing. So there's many options, but most people, so let me start at the beginning. So if it's very early, what we can actually do, and some men opt for this, is what we call active surveillance. I'll say a few more words about that in a minute. So what we do is we just watch you, but we watch you carefully. And then if things start to change, we can move on to more what we call invasive treatments. Many men are not comfortable with being watched. So even if it's very early, so they may opt to have surgery. And there's 3 different types of surgery, and we'll go into that in a second. We can also use radiotherapy, and we can also use hormone therapy. So let's go through some of those things and explain them in more detail. So active surveillance is folks who have low risk and low volume. So you may have a little tips of prostate cancer. And remember, we're talking about the grade. So if it was low grade, one spot in one half of the prostate, you may say, you know what, doc, why don't we watch it for a little bit? Because sometimes it can stay like that for years. And you may not really need anything more than just observation. But it may be that, it's a little bit more advanced than that, and you watch it for a little while, and then PSA is going up, and everybody's like, okay, it's time to move towards something more radical, like taking the prostate out by surgery. If the gentleman is quite old, let's say the person is in their late 70s or 80s, and they may have a lot of other issues that are actually much more problem to them than their prostate, like heart failure or severe diabetes, we may just do the same watching. And we can also offer hormone treatment without doing anything major like surgery. So we can discuss all of those things maybe in the question time. But I'm going to talk now about prostate cancer surgery. So taking the prostate out, the term that we use is radical prostatectomy, which means you take out the whole prostate, and usually you would take out the seminal vesicles, which were those little ear things that sat behind the prostate, on the top of the prostate. So there's 3 different ways nowadays that you can have prostate surgery. You can have what's called open prostatectomy, whereby the doctor makes a cut just above your pubic bone in your lower abdomen and takes it out through that incision. And that is in fact the most common surgery available in Jamaica. It can also be done by what we call keyhole surgery, which is literally that. So the doctor makes usually 4 or 5 little cuts, very small cuts in the abdomen, lower abdomen, and then they will put their instruments in and look down a type of microscope, and they can dissect and take the prostate out through the very small hole. So it means it's only a couple of people do it in Jamaica, but there's short recovery time, less blood loss, and those kind of things. So that's a good way to have your prostate out as well. And then the way of the future, which is unfortunately not here yet, but in the US, it's done by a doctor. Well, you can see the picture there, and we call it robotic surgery. And some folks who have really good insurance and so on would even go up to the US and get their prostate done robotically. I imagine if we're doing this talk in 5 or 10 years' time, we may have a robot in Jamaica, but you can imagine it's quite an expensive undertaking. So it's in our future, not currently in our present in Jamaica. So in Jamaica, we have open and laparoscopic prostatectomy is available. So now we just need to talk about radiotherapy. So radiotherapy or radiation therapy is using special focused high-powered X-rays to shine at the prostate and to try and kill the cancer in that way. So why would we choose radiation therapy over surgery? So some people just afraid and they're not going to have the surgery done, and that can be a reason to do the radiotherapy. But sometimes, even though the person would prefer to have their prostate taken out, the risk of putting that person to sleep for a major surgery might be too great. So the person who puts you to sleep is called the anesthetist. And the anesthetist might assess you and say, boy, sir, you know what? Your heart isn't in great shape. Your pressure is high. You've had sugar for 30 years. We don't really want to put you to sleep. The risk of complication is too great, at which point the surgeon may say, okay, and refer you to the radiation therapist, the radiation oncologist, who would then talk to you about radiotherapy. So radiotherapy now is, you don't feel anything, nothing touches you. It is literally like having an X-ray. And the radiation is delivered in small doses every day, generally over a 7-week period. So most people would have about 35 treatments for their prostate cancer. So we can't give that dose all at once. We give it a little bit at a time, Monday to Friday, over about a 7-week period. Doesn't require a stay in hospital. It's an outpatient treatment. The other time we use radiotherapy is if you have had surgery, but so once you've had surgery, we still follow your PSA, because if you've had surgery and your prostate is gone, your PSA should really be 0. But sometimes a little bit of the cancer is left behind, or it was in one of the glands in the pelvic area and the doctor was not able to take out all the glands. There's various reasons why the PSA might still be not 0 and might increase in the months after the surgery. And we might do a scan and we might not see anything at all, but we know that there's microscopic disease, meaning not seen by the naked eye, but there's still something going on because the person's PSA is inching up. At that point, the urologist who has been following the patient may then send you to the radiation oncologist to say, listen, can we do what we call salvage radiotherapy to see if we can mop up any of those little cells that may still be producing the PSA and that are cancerous. So we quite often do post-operative radiotherapy as well. So it has quite a lot of uses, as it were. And we'll also say a little bit in terms of if the prostate cancer has spread and causing problems in the bones, we can also use radiotherapy at that time. So the other picture you see here is a picture of something called brachytherapy, which is offered in Jamaica, currently in the private sector, but we are hoping to also be able to have it in the public sector. And what this treatment is inserting either radioactive seeds or radioactive seeds that may stay in the prostate, or radioactive seeds that are just put in the prostate for a short time and then removed. And that's called brachytherapy. I'm not going to go into detail because you have to have very low risk prostate cancer to have this, and in the private sector it is fairly costly. But it is a way of treating early low-risk prostate cancer, and sometimes that's all you need is that brachytherapy with the radiation seeds inserted into the prostate and left there. They become inert after a short time, but they give a high dose of radiotherapy just to the prostate gland. So moving on. So the other thing that is very important to understand is that prostate cancer grows it uses the male hormone called testosterone for its food, which is unfortunate, but that is the way it goes. So testosterone is the prostate cancer cell's food. And so another way that we think about trying to slow down the rate of growth is to reduce the level of testosterone in the man's body. So that can be done in many different ways. So in the older days, and is still used, but obviously, it's not something that men love, but actually removing the testicles is an instant way of reducing the testosterone in the body. And when I first came into med school, which is now like 30 odd years back, we never had all the new fancy drugs that we have now. And that was one of the main treatments for prostate cancer, was removing the testicles. Nowadays, we have medication that can do that. So you may hear people say, oh, I'm on hormone treatment. It's interesting we call it hormone treatment, but it's actually anti-hormone treatment, because these injections, they're usually tablets or an injection that you may get either into the muscle of your bottom, or some of them are given into the front of your tummy, just into the fat of the belly there. That's given once every 3 months. And what that does is it acts on the brain to stop the signals that come from the brain to tell your testicles to produce testosterone. So that's another way of reducing testosterone in the body. It's important if you are diagnosed with prostate cancer, whether it's in the public sector or the private sector, to make sure you get an NHF card, because you will get a good discount on those medicines if you have an NHF card. There are side effects from the hormone therapy, and that can include erectile dysfunction, hot flashes. So gentlemen, you may suddenly realize what your wife was going through at change of life when you were laughing at her. You may get that with your hormone therapy. It can cause you to put on a little weight. So I'm just going to talk last slide or last couple slides here now, just to finish about the hormone therapy. So that can go along with radiotherapy. Sometimes it's given before you have surgery to reduce the size of the prostate before the surgery. We quite often give it along with radiation therapy for a while to, give the best outcome. And we often give it if the prostate cancer has spread, and then that becomes one of the mainstays of treatment. So when a cancer has spread, we say it's metastasized. Now, that's often a difficult word to get your tongue around, but metastatic prostate cancer means it has spread from the prostate. And the most common place that prostate cancer spreads to is the bones. So, and generally the bones of the back. So you might remember that little old guy going, "Oh, my back is hurting me." You do not want to find out that you have prostate cancer when your back is hurting you, because that generally means it's in your bones and it is then treatable but not curable. And then you can have all kinds of problems. Sometimes the bones can collapse, squeeze on the spine, and the person loses function of their legs. And you're not able to hold your urine or your stool. It's really not a pretty thing to happen, but it's unfortunately very common. It can spread to other organs, but principally it's the bones that is the issue. It can spread to the lungs, it can spread to the liver, and so on. So at that point, we can't cure you. We can treat you. We can give you hormone treatment to reduce the cancer's activity. We can give radiotherapy to the painful bones. Sometimes it can cause bleeding in the urine. Again, radiotherapy can help reduce the bleeding, and so on. So it's not that there's no hope or no treatment. It just means that it can't be cured. So that really wraps up what I had wanted to say. So just in summary, it's a major public health issue in our country. Unfortunately, Afro-Caribbean people are more at risk. And so, reducing your risk by improving your lifestyle for all types of illness, but will help reduce your risk of prostate cancer. Care is individualized, and it really depends who you are, how old you are, how advanced your cancer is, and what options are available. And yes, research is ongoing, and we are indeed doing research in Jamaica because we think that the biology of the cancer, prostate cancer in Jamaican men, is different. And so we are working with people overseas to look at, in particular, Jamaican men's tissue from Jamaican men's prostates to see how it differs from white folks and how we can develop drugs that might be more appropriate for our people in Jamaica and the Caribbean. And with that, I thank you. So I'm going to hand back to the Lions Club at this point.
Thank you very much, Dr. Spence, for that presentation. I'm actually not the one who will be doing our vote of thanks. However, I know you had said it earlier, from our audience or members here, Lions and guests and Leos, do you have any questions? I know some of you would have joined a bit late based on the challenge that we experienced on our YouTube live stream. But from what you would have heard, do you have any questions for Dr. Spence? If it is that you don't want to speak, you can definitely type it in the chat. Go ahead.
Yes, I have one question here. Sure. Hi, Dr. Dingle Spence.
Good evening. The audio is not
pertaining to lifestyle. already what I'm hearing is scaring the daylights out of me, but I suppose I should not
I
do
think I
that.
missed the first
But you
part of your
mentioned
question
something.
because the audio was not so good. Could you just start again?
No, my question really speaks to that of charred food, which you referred to, and I think specifically grilled foods. So, what is there special about charred foods? Is there anything special about that? I would have thought that that's on the healthier side because that's avoiding oils and that sort of thing, cooking over the
Well,
flame.
you're right that avoiding oil and frying things in deep oil is generally not recommended. I think there's some chemical change that happens. So when I say charred, I mean you can still grill, without charring. Charring is when things start to get blackened. And I mean, if you're going to have your blackened whatever meat kind once a month, once every 2 weeks. But I think the issue is having that kind of thing every day, over a long period of time. The body is quite good at dealing with what we call an insult now and again, but it's not good at when you're constantly doing it, constantly. Like smoking, if you're going to smoke and you smoke one cigarette once every 2 weeks, that's probably not going to give you lung cancer. But if you smoke it 10 cigarettes a day, then you're definitely at risk. So I think I would never tell you don't eat charred food or, your jerk chicken or whatever it is that's a little bit burnt. But don't make that your main food that you have every single day. I think moderation is the key because we all have to live, right? And we have to enjoy ourselves. So we are going to be doing things that might put our health at risk. But if you do that now and again, that's different than a regular habit.
Okay, and a quick follow-up one. You mentioned something about core samples, which the doctor may take at a particular time. Do those samples, and I gather, means pinching out or um, digging into the
So
prostate? Does that hurt?
yes, no, they will give you a local anesthetic. So you may be uncomfortable, but it's not painful. So if that is your prostate, in order to, sorry, this is not a good, I don't have anything here, but basically the doctor does need to pass a needle into the gland some way and then pull it out. So the needle is a hollow thing and you push it in and then you pull it back out and there's a core of tissue, to the length of the needle that was put in. And then that is then removed in the lab and cut finely so that the pathologist can have a look at all of the slices. And they can be very precise and they can say, well, that core came from that part of the prostate and that core is fine. But unfortunately, in the left lower part of the prostate, that's where the cancer seems to be. And that's good information for us who might be treating it, because then we can focus our treatment more on the more at-risk areas.
Thank you.
Welcome.
Good night, Lions and Leos. Good night, Dr. Dingle Spence.
Good night.
I have a question. What's the side effects like for men who have gone through radical that word.
Having your, it's tough, isn't it? Prostatectomy.
Yes, it is.
The side effects.
Yeah, there we go.
Okay.
What's the side effects like?
So, I mean, there's obviously always side effects from just recovering from surgery. So when you have your prostate out, you have to have a catheter. Do you know what that is? So that's a tube that goes through the penis into the bladder, so that you can pee through that for about 10 days. So that's, not fun, but most folks deal with it. And then the doctor will take the catheter out, and there may be a little bit of urinary leakage for some weeks to months. And that can depend on the technical expertise of the doctor, and also, whether you have what we call incontinence or leaking. It can also depend on whether you have other issues like being very heavy and so on. But mostly that people become dry after a period of time, meaning you can hold your urine perfectly. And then of course, the nerves that work erections are right next to the prostate. So if the doctor can do what's called a nerve sparing operation, so that your erectile function is maintained. But sometimes folks are not so lucky, or the cancer is spreading outside of the prostate and they have to cut the nerve. So definitely erectile dysfunction can be a problem.
Okay, thank you. Another question I have was, what's the palliative care like for men with prostate cancer?
Well, if you come to the Hope Institute, it's fabulous. And you'll have me and Nurse Hanson, Sister Hanson, looking after you. You know, palliative care is about what I would call relief of suffering. And people with cancer that are spread around the body can suffer in many ways. So, you know, we think of the physical suffering. You might have pain, depending where it is in the body. It might stop you walking, as we said earlier. So there's all types of things that can happen. So our focus is on relief of suffering. So how do we get you out of pain? How do we support you psychologically? Do you have, you know, all of a sudden now you can't work? Let's say it happened to you when you're 60 and you were still working. We have a social worker who can help you access whatever benefits might be available. So what we do, palliative care is about looking about the whole person. We have a counselor who can, you know, help with the psychological side. So it's whatever the need of the person is, we try and meet it. And the thing that I love about palliative care too is not just about the sick person, it's about supporting their family as well. Because of course, if you are very ill, it's not just you suffering, it's your family suffering too. So how do we help everybody involved?
Okay, thank you.
Right. Do we have any other question for Dr. Spence? All right. And see, if there are no other questions, Dr. Spence, and before we do our vote of thanks, we have two special persons here online with us this afternoon. You know, in our Lions Club, we have our region chairperson, and Dr. Paulette McGregor, and our zone chairperson, Lion Harris Harper. And I would like to know if either of them would like to say, you know, something before we go into our vote of thanks. And Paulette.
Good evening, everyone. I trust I find everybody well. I listened to the presentation, very, very informative, very scary. But I suppose if we follow the instructions from start by eating right and doing exercise and all that sort of thing, we should be okay. But we are mostly an indisciplined set of people, and this is what is causing the problem. But I have no questions as such because the presentation was very, very clear and informative. Thank you so much, and thanks for the opportunity to be in attendance.
Thank you.
Thank you.
Sorry, Lion Siobhan.
Yes, Lion Ali.
I have a question for Dr. Spence.
Go ahead.
I don't know if you can. I don't know if the answer is readily available. What is the scientific reason as to why prostate cancer is so prevalent among Afro-Caribbean men?
So that's a good question. And we still don't really know 100% why. We think that we have some slightly different genetic makeup as African people, or, you know, descended from African peoples. And that's a lot of where the research is going, you know, is looking at our genetic makeup once a person has cancer to see, you know, what is different about prostate cancer in Afro-Caribbean peoples different than in Caucasian peoples. I do think, I don't want to over-labor the vitamin D thing, but you know, I think that we will find that there's more to it, and that vitamin D may be a part of the picture. I think the thing about these things, there's no one reason. There's no one cause. There's no one answer. So it's going to be a mixture of, you know, our own genetic makeup and then lifestyle as well. So sorry, I don't have the quick fix answer for that. Maybe in 10 years we'll know, though.
Thank you very much. Thank you. Lion Caris. Lion Caris, are you hearing me? All right. So if Lion Caris is not hearing us, Lion, so again, thank you very much.
Just found my microphone.
Oh,
I'm so
right.
sorry.
That's okay. Go ahead, Lion
I'm
Caris.
so sorry. Thank you so much. Special thanks to Lions Club of Mona for really hosting this important seminar or talk. It's very interesting. And thank you, Dr. Dingus Spence, for making it so easy to understand. I have learned quite a lot from your talk, very interesting and well appreciated. Thanks to all. Okay.
Thank you very much, Lion Zone Chair. And I'll just now go ahead and hand over to the member of our Cancer Awareness and Action Committee, who will move the vote of thanks for this evening.
Thank you, Lion Trevon. Dr. Dingle Spence, on behalf of Mona Lions Club, we would like to say a hearty thank you for your presentation. As a young man, I learned a lot. I am very much familiar with prostate cancer. I have family members who have the disease. So it was very informative. So I'm here, I was listening to you, and the thought process ran through my mind as a touch party. Signs are no sign, get tested. So even the question I asked about being at a higher risk, those are some of the concerns I have as a Afro-Caribbean. But you have clearly demonstrated your in-depth knowledge. You made it so easy. That long word, I can't even call it. You said it with such ease. Clearly, you are very adept at treating, at taking care of patients with prostate cancer. So on behalf of the Lions Club of Mona and the Cancer Awareness Committee, we'd like to say a big thank you for your time, for your effort, for educating us, and for passing on some very valuable information, particularly for young men. Thank you, Dr. Spence.
Yeah, most welcome. And if I can, if one person awareness is raised out of this and, gets tested and we picked it up early, it's sure worth it. So I'm really glad to have been able to be here with you. And I think I would have to say, I hope I never see any of you in my office because you're all going to be taking care of yourselves.
Definitely. And thank you again, Dr. Dingus Spence. And, it wouldn't be good, if it is that I, first of all, again, apologize to our members who are here, again, who were waiting for a YouTube live stream, but at least some were able to join us on Zoom. And I think I'd like to give the final word for this evening to our Lion President, Lion Melissa, and then we'd actually say goodbye and we'll go and have a good night's rest. Lion Melissa. Lion President. Lion Melissa.
She's having a good night's rest already.
All right. So,
okay.
that challenge. Again, thank you very much. And I thank everyone for joining. I say even though this presentation was hosted by the Lions Club of Mona, we couldn't just take the information for ourselves. And I've seen the comments in the chat, expressing gratitude for us allowing members within the region to join with us. So we had to share the information that we are getting from you. And I'm happy that they were able to join us. And again, I'm happy that you accepted and you joined us in this presentation. So have yourself a wonderful evening, rest of the night, and stay safe. Wash your hands, wear your masks. All right, have a good one.
Okay, thanks. Good night,
Thank you.
everybody.
Good job.
Bye. Bye.
Thank you too.